Yeah, I have the poster brought up. I'll just get through this in 10 minutes too. I have a slideshow as well, but I think for this purpose, the poster might be most effective. So thank you all for bearing with me while I go through a lot of information in a very short time. Just to get a little bit more about the background and dive into it. One of the critical issues that we really have affecting our pediatric surgical care here at Children's is what I wanted to talk to you all about today. So my name is Dylan Salrin. I'm an ASC administrator and director of nursing for Novant Health. But this work is a part of Children's Colorado Hospital and the University of Colorado Anschutz Medical Campus for my time there. So this is really focused on addressing equipment limitations and how we can advocate for device innovation, regulatory change, that sort of thing to protect our pediatric population, right? Our most vulnerable patients that we could imagine. So one population that I came into contact with at Children's that starkly revealed these gaps was children with epidermolysis bullosa, right? Or EB, as most people will hear it. So for those unfamiliar, EB, it's a rare genetic condition, causes extremely fragile skin. So the layers of our skin on a normal human have these proteins called collagen, right? And that's going to keep your layers together. When you have a condition like EB, that collagen is gone. So I tell people unfamiliar with it to kind of imagine like a croissant, right? There's just nothing there between those layers. The slightest friction, adhesive, heat, that's going to cause painful blisters, even wounds, and we're talking deep skin damage. So it's a very, very sad and a painful condition that these kids are dealing with. And they require a super delicate approach during procedures and surgery. So unfortunately, many of the tools that we rely on in the operating room, they're not designed for these children in mind, right? And we'll learn that most equipment is not designed for children at all, right? Our textbooks and our lessons and everything we're taught in school is more tailored towards the adult world. And in pediatrics, we found that we have to fill in those blanks and use critical judgment and knowledge and infer these kinds of things. So a prime example is the adhesive electrosurgical grounding pads. So these adhesive pads, they're standard for most patients. They are to connect the circuit for like a cautery pencil that we would use to seal vessels and dissect tissue and that sort of thing. So they're, however, contraindicated for our pediatric population with EB because of that adhesive that they require to be put on. That's going to cause your skin tears. That's going to cause your breakdown and wounds. So the safer alternative, which for adults can work, which is a non-adhesive pad that goes underneath that patient. However, that same pad was recalled years ago by the FDA for use in children under 12. And then that also goes up to anybody under 50 pounds. So we find ourselves in this difficult position, right? We either avoid surgery or we modify our equipment against the manufacturer's instructions that we know could harm that child. So this all went through my head about 6 months ago. I wanted to understand how widespread this issue was, what strategies we can use to kind of drive this change, because this is a huge gap for a really big population. EB can affect between 25 and 50,000 people in the US. That's recorded, so many more internationally. And in the US, there's just not a great solution, even in progress. So what I found was concerning, but it's also familiar. It's what we already assumed, right? That teams reported to routinely have to choose between these essential surgeries or using these adult design tools with serious risks. Some used bipolar cautery that didn't use the pad at all. But bipolar cautery is more like a pair of tweezers. It's not like a pencil that we can dissect with or get a larger, more acute type of surgery requiring more intervention. So we found that the monopolar was limiting our effectivity, our practicality of certain surgeries. It just wasn't an option. So a real safe choice that ethically we could recommend was to not do the surgeries at all, which is just not an option for some of these kids. So we had doctors start modifying these adhesive pads by cutting off the adhesive around the edges. Well, you're cutting a electrode for one, and by doing that, you risk violating the warranty, violating your instructions for use, causing burns. You're changing the frequency of that electrode. So just so much is wrong with that, where we go back to the drawing board, right? So these aren't best practices. They're stopgaps, right? And we're speaking to a larger systemic issue that our pediatric population, specifically those with EB, are forced to fit adult tools instead of having developed pediatric specific solutions. So that's why, what I consider nurse leaders, but leaders is an ambiguous term. It could really be a staff nurse, right? You don't have to necessarily be in a position of a coach to be a leader. So when I say nurse leaders, I say how you can drive that meaningful change. And I broke it down into kind of a multi-pronged approach quickly on the poster I'll touch on by collaborating with the industry, right? We can bring this clinical insight into project development and product development, sorry. Manufacturers by background and in my experience, they're engineers, they're marketing degrees, they're MBAs. They take some input from physicians on their payroll, but manufacturers really need to hear from those at the bedside because this has not been escalated. And it's what brings me into the second point, right, is leveraging research to highlight that the harm of using these ill-suited equipment, it's there, right? It's happening on a day-to-day basis. So quantifying those injuries and then, reporting that through audits, through, FDA cases, through presentations like this, it strengthens the case. And that is the same thing as advocating through professional organizations like ARN, APSNA. They already have these clinical pathways to influence that policy and really connect with those regulatory bodies. And we obviously know there's formal petitions. Those are a little harder to get into as a healthcare professional that has really no exposure to them, which is why I always push to get in touch with those professional organizations you may already have memberships through. And then just launching those awareness campaigns. Kind of what I'm doing is booking these opportunities to spread the word, because if you're not working in the OR, you likely have no idea that something like this is even possible in today's age. But as you go down, I don't know if you can see on the poster with our grounding options visualization there, that is every single manufacturer that we have in the United States. And not a single one of them has a solution, is developing a solution, or has the financial motive to pursue something like this. So in short, we really have to stop accepting workarounds as the norm, right? And unfortunately, that applies to so much in healthcare. But I want to underscore how important it is for us as leaders to kind of push the equipment, push the unique needs of children, not just in EB, but across, pediatrics as a whole. So I will open that up to questions. I definitely didn't cover absolutely everything. I am available if anybody wants to connect afterwards and get in touch with anything else you guys may have experienced. But yeah, I will open it up.